afternoon, and good evening, everyone. Welcome to today's webinar. Our webinar is Pneumonia in Focus, Clinical Impact of Rapid Respiratory Diagnostics, hosted by bioMérieux. My name is Kelsey Brown, and I'll be your moderator for today's session. So before we begin, just a few housekeeping items to keep in mind. Today's event will run for approximately 60 minutes, and that includes time for Q&A at the very end with our speakers. Your microphones are automatically muted, so that will minimize background noise. But if you do require assistance at any point in time, just give me a message with your control panel, which should be sat in the very top right corner of your screen if you haven't seen that already. We do encourage you to use the same control panel to submit questions during Q&A, so you can send that throughout the webinar or towards the end during Q&A at any point in time, and then we'll address those once we get to the end of the webinar. And then just in terms of recording, so we will record today's session and we'll share the recording with you after the webinar is complete. So now it is my absolute pleasure to introduce you to our speakers today. Joining all of us today from Italy. So we have Dr. Vittorio Sambri, Professor of Medical Microbiology at the University of Bologna, Dr. Stefania Stefani, Professor of Microbiology and Clinical Microbiology and Laboratory Head at the University of Catania, and Dr. Michele Bartoletti, the Associate Professor of Infectious Disease at Humanitas University and the Head of Infectious Disease Unit at IRCCS Humanitas Research Hospital. So not only are our speakers respected experts in infectious disease and laboratory medicine, but each is also a co-author of a recent publication in press since August 2025 in clinical microbiology and infection. The role of rapid and advanced microbiological methods in critical care, 2025 Emanuele Russo Delphi Consensus. So while the article provides consensus recommendations across a range of diagnostic tools and clinical scenarios, today on World Pneumonia Day, we will focus specifically on challenges and recommendations related to lower respiratory tract infections. So with that, let us begin our session today by welcoming Professor Sambri.
Hi, thank you, Kelsey, for the introduction. Thank you for all the people that are listening to our lecture this afternoon. So I will start this webinar talking about pneumonia fundamentals and major consensus recommendation. So if I can have the second slide, please. These are my potential conflicts of interest, and please check it carefully. Okay, so we can move. So I don't want to go too much into detail in clinics because I'm not a clinic doctor. I'm a doctor working in the laboratory since the last 35 years. So I probably I was forgetting everything, but you know, just to make a clear picture, what we are discussing about this afternoon is we will be discussing about pneumonia. Pneumonia is one of the feature of the lower respiratory tract infection, apart from bronchiolitis and bronchitis. And of course, when we talk about pneumonia, we talk about a series of possible different microbes involved within the etiology as causative agent of this very complex clinical picture that Michele Bartoletti will for sure describe much better than what I can do now later on. So my talk will be focusing on what could be useful for detecting these pathogens in the clinical microbiology laboratory. And if you check at the very bottom of the slide, the list of the main etiological agents of pneumonia, it's an impressive list because this list encompasses more than 10 different bacteria with very different features, one from another, and of course, a lot of different viruses and also fungi. So we are dealing with one clinical picture that will not be so simple, but you know, basically one clinical picture that can be generated by many different etiological agents. So having this capability to make this is a result of a search that I made early this morning in PubMed, and you see that for many here, over 1 century, there was a very limited amount of paper published year after year with the laboratory diagnosis pneumonia as keywords. Of course, there is a huge and sharp peak that correspond to the COVID-19 pandemic. And again, it's very interesting that after this sharp peak, more or less corresponding to 2020 or 2021, there is a strong decrease. So that means to me that pneumonia is perceived as a as a disease that can be diagnosed not so difficultly. And this is because the interest of the scientific people is not so sharp in anymore after the COVID pandemic. But let's see. Let's try to go ahead. And this is a very simple classification of the pneumonia in CAP, that means community-acquired pneumonia, that has Streptococcus pneumonia and Haemophilus influenza as the most commonly identified germs, hospital-acquired pneumonia that start 48 hours after the hospital admission, and in this case, the mostly involved with microbes are gram-negative and Staph aureus, and the VAP that is, again, starting after at least a couple of days of staying in hospital, and that is absolutely linked to mechanical ventilation procedure, is mainly generated by multi-drug resistant gram-negative that are inside the hospital. Of course, basically the laboratory diagnosis of these 3 different type of pneumonia are, based on the identification of the involved germs by using culture-based technique. That can be done on sputa, that can be done on tracheal aspirate, and can be done on quantitative BAL, but basically what we commonly do is just start and try to grow in a semi-quantitative way the germ that are involved. So may I have the next slide? So what does the diagnosis of pneumonia is based on? So it's an integration of clinical evaluation, imaging, and laboratory testing. In other words, it's impossible to make a diagnosis of pneumonia only working on thinking about laboratory testing result. The final goal is to identify the pathogen, thus allowing the pathogen-derived therapy and assess the severity. Because of course, if we are lacking data about the etiology of these single cases of pneumonia in our patient, we cannot start the pathogen-driven therapy, and consequently, the final outcome will be less successful and less favorable for the patient. So may I have the next one? So we have also some very simple blood tests, like the complete blood count, detecting either leukocytosis or leukopenia. We have CRP and ASR that are usually elevated in cases of bacterial etiology for the pneumonia. And also there is debate about the use of procalcitonin that likely could help in distinguish bacterial versus viral. But this is not our task this afternoon. Please go on. What kind of biological sample we usually use to make the laboratory approach for the diagnosis of pneumonia? Tracheal aspirate or BAL that are very useful for pneumonia or ventilated patient. And we need also to consider that these 2 types of biological sample basically can be used to set up a quantitative culture and also a PCR, a multiplex PCR. Of course, it doesn't make any sense to start quantitative culture and PCR, especially PCR in sputa, because in sputa you got a lot of microbes from the upper respiratory tract microbiota, and these microbes can also include Streptococcus pneumoniae in about 30% of the cases in adult population. So we must be very careful when we are going to apply this kind of setting in the clinical laboratory in order to avoid to detect the normal microbiota of the upper respiratory tract.
May I have the next slide, please? So in summary, what we can do is use an integrated approach. We need clinical, imaging, and lab data all together. We need to collect the respiratory sample before the antibiotic prescription, before giving any therapy, whenever it's possible, and this is not all the time the case. PCR and antigen test, I remind you that for Streptococcus pneumoniae and Legionella pneumophila, there are very nice tests that can detect the specific capsular and not capsular, for in the case of Legionella, antigen in urines, that are, you know, a very helpful additional tool for the achievement of the laboratory diagnosis of pneumonia in those selected cases. And deep sampling like BAL are available in severe cases, and I would say in all the cases in which is not so harmful to collect the BAL, I strongly suggest that BAL should be considered as a standard, as a gold standard for the identification of pathogen in pneumonia patient. May I have the next slide? So, but nowadays, today we are talking about rapid microbiology, and rapid microbiology is basically available thanks to these guys, Dr. Carrie Banks-Mullins, that was awarded the Nobel Prize in 1993 for the development of PCR. And without this very smart intuition about the possible use of DNA polymerase that worked at high temperature, we will not be today talking about this huge amount of and very powerful tech.
I think we lost your audio there.
Hello?
Oh, there we go.
What's wrong?
We can hear
Maybe
you.
the next one. Okay, so we are talking about a story that started many years ago. Whenever I'm called to talk about use of molecular microbiology in the respiratory tract infection in the clinical laboratory, it's very useful to me to remind that one of the very first papers describing the relevance of NAT for this kind of infection has been published more than almost 30 years ago. And the conclusion that these colleagues were stating in this very old paper was that at that time, the molecular diagnostic technique were currently in a stage analogous to that of the clinical bacteriology technique in the 60s. So we are moving a strong and a very relevant step forward in the direction of molecular microbiology. But again, this is a story that started many years ago. So may I have the next slide, please? So again, when we talk about molecular testing for respiratory tract infection nowadays, we have a huge list of possible different, association between different technology like antigen detection, chemoillumination, or PCR, or other stuff in the field of nucleic acid amplification. And what is really relevant for us is to decide which one is the best one that we can apply in our clinical setting. So it's a huge list, and we need to decide which one should be the right one for us, for each single laboratory. May I have the next one? When we talk about the possibility to introduce molecular microbiology, rapid microbiology in the workflow for respiratory tract infection. Well, this is a paper that has been published by the Infectious Disease Society of America a couple of years ago, if I correctly remember, but anyway, so before the COVID. The first step is to state the technical efficacy and the diagnostic accuracy and efficacy. Then we need to move and to identify the value in the diagnostic workflow that we can get by using this type of technology. And then, of course, the therapeutic efficacy. At the very end, the patient outcome will be the most realistic parameter that we can use to state if the introduction of this kind of rapid microbiology makes sense or not. At the very end, in addition, we need also to consider the societal efficacy of this introduction. So may I have the next one, please? It's a very simple recommendation, but I believe that no one should forget that the value of the different molecular tests are widely influenced by the setting in which the tests themselves are included. In other words, if you look at this table, the prevalence of positive rapid molecular respiratory tests using in influenza-like illness makes a very different positive predicted value depending on the percentage of positivity. So if we have a very low prevalence, the positive predicted value will be extremely low. If the prevalence is
Professor Sambri, we lost your audio. You might want to adjust the headphones. Or maybe they've lost battery. No, yeah, we still can't hear you. Oh, there we go. Try one more time.
Can you hear me now?
Yes, perfect.
Can you hear me now?
Yes.
Okay, good. I'm sorry. I don't know what was wrong because, you know, the button for the microphone is green, but well, anyway. So
No
may I have the next slide because I need to speed up a little bit. So of course, we need also to know which are the most at-risk population, most relevant population that must be investigated by using molecular testing for respiratory tract infection and for pneumonia in particular. These are data that we collected in our laboratory, and as you can see, from 2020 to 2025, there is quite a stable curve that is very different in the ratio of positivity according to the different age group. So the most affected age group is the group in between 1 and 6 years of age, while the older people, that is in green down here, has a very low positivity ratio. So we need to focus when we need to make a decision on which population should be identified as a higher risk. May I have the next slide, please? So let me introduce the result of the consensus conference that we.
Important thing for me to remember that this guy, that is Dr. Emanuele Russo, that was the inventor and the first person that wanted to have these consensus conference made with the Delphi method, suddenly died 11 months ago. And so we were working to publish this paper with a particular, feeling that was, we owe it to Lele, that was the very relevant person in having the idea and in collecting all the people together, because this consensus conference has been involving almost 40 different persons in the first step, coming from microbiology, infectious disease, ICU, and pneumology. So it was a very great experience that we realized thanks to this guy. May I have the next one, please? So in the very last part of my talk, we will discuss and I will provide to you some summary of the key recommendation that this consensus conference achieved in the case of pneumonia patient in critical care units. May I have the next? So we had basically a set of final result questions, so that are dedicated to pneumonia patients. So these questions state in critical ill patient with community-acquired pneumonia, is rapid microbiology testing for respiratory sample indicated over the standard testing in terms of pathogen identification time, cure rate, mortality, ICU, length of stay, hospital length of stay, and mechanical ventilation duration. So the basic rule of this Delphi consensus was that we accepted the final statement, that is the sentence you see here in green, when the strong agreement was at least 70. Of course, this has been performed by, thanks to the huge range of the literature available for each single question, and a final evaluation made altogether and voting for the statement. So giving an answer to this question is, in critical ill patient, the panel that we had available with severe community with CIP that has a clinical and radiological risk factor for failure of standard therapy, this panel suggests the use of rapid microbiology testing, basically PCR-based syndromic panels, on lower respiratory tract sample. In addition, please be, I want to underline that this is in addition to the standard microbiology testing to improve the pathogen detection rate, provide earlier results, and enhance precision in antimicrobial management. The agreement was 88.1%. The disagreement was 0, and the quality of evidence was unfortunately only moderate. May I have the next one? So the following question is about the patient that are suffering from ventilator-associated pneumonia. And again, the question is, does it make sense to test these patients with rapid microbiology testing over the standard test in terms, again, of pathogen identification? Can you hear me?
Yes, we can hear you now.
Okay, good. So the panel stated that in these VAP patients, and also in the case of ventilatory hospital-acquired pneumonia, it makes sense with the strong agreement of about 100%, 0 disagreement, to approach the diagnostic problem with PCR-based syndromic panels, in addition to standard microbiology testing. Again, we got a moderate quality of the evidence, but the agreement was absolutely higher and there was no disagreement. So that means probably in VAP and VHAP patient, it makes more sense than in CAP, moving in the direction of rapid microbiology. The next one, please. So now the question is, what kind of biological sample should we use? And basically, does it make sense to test from lower respiratory tract sample in terms of bronchoalveolar lavage, that is or not preferred over a bronchial aspirate in terms of rate of pathogen identification? So again, in these patient, in critical ill patient in the ICU, the panel suggests that the current evidence is not sufficient to recommend the use of BAL over bronchoaspirate for rapid microbiology testing. However, the deep respiratory sample should be considered more appropriate than endotracheal aspirate or sputum. And again, you see here that the agreement was 90.7%, but we had also some disagreement, 3.1, and the quality of evidence is very low. I mean, the quality of evidence is directly connected to the amount of data we got from the literature, basically. So I think we have another question. May I have the next one? Yeah. Again, this question was about the possibility to use digital PCR for the diagnostic of these patient critically ill with pneumonia. And the panel statement was that there is no enough evidence to support the use of digital PCR, that is an emerging technology in the field of clinical microbiology, either in terms of turnaround time and identification rate. Digital PCR could also be applied to the assessment of the antimicrobial susceptibility profile and the pathogen load. The agreement was very high, no disagreement, quality of evidence low. In other words, digital PCR is nowadays not to be considered as a test that can be used for the diagnostic of this patient. I think we are almost done. Oh, we have another one. In the critical patient, should bronchoalveolar lavage be preferred over bronchial aspirate? The panel stated that in this patient with indication to advanced microbiology testing, there is insufficient evidence to suggest that BAL or bronchial aspirate is better than normal sample for the application of rapid or advanced microbiology testing such as metagenomic next generation sequencing. And also in this case, the agreement was almost 83%, but as you see here, the level of disagreement was quite significant. And again, the quality of evidence was low. May I have the last one, I guess? I took it also too much, and thank you for your attention. And of course, I'm open to any question you may have. And I think I pass the stage to Michele.
Hi everyone. Thanks, Vittorio, and thanks because you already started with a good overview about diagnostics. So in the next slide, I will focus on this, but we'll go very fast. And thank you, Vittorio, for the memory of Emanuele Russo, because you know it was very hard to this loss for us. So I said the microbial diagnosis of pneumonia, according to the guidelines, current guidelines, is recommended especially for patients with a severe CAP and patients in which we may use a broad spectrum therapy, so there is a higher risk for resistant pathogens, and those who we wanted to broaden the spectrum of our diagnostics, such as immunocompromised patients. And this also would apply for hospital-acquired pneumonia and ventilation-associated pneumonia, as these syndromes can have a broader spectrum of pathogens and also risk for resistant pathogens. So in the next slide, and the next several slides, I will try to put my perspective into the use of rapid diagnostics using some clinical cases. So the first case is a 71-year-old male with history of chronic kidney disease, hypertension, that was admitted in September for heart failure. And a couple of months later, he was readmitted for community-acquired pneumonia with the need for non-invasive ventilation. So he's a very severe patient with, and in Italy, at least, this kind of patient with comorbidities, elderly patient with the recent hospitalization, we think that this can be a patient at risk for resistant pathogens. So we generally start with a broad spectrum antimicrobial therapy, piperacin, tazobactam, and nasal azithromycin. So in this case, we wanted to perform a deep respiratory sample. So in this case, it undergoes BAL. And in the next slide, I will show you the results of rapid test. So the bioviral pneumonia panel plus showed that he has a Klebsiella and it was a CT-exam positive. So the question would be, can we safely discontinue nasal azithromycin, and what to do with piperacin tazobactam? To answer this question, Louis, you can start to think about it, but I will show some clinical data from randomized clinical trials. So this is the first clinical trial I want to show you. This is a trial conducted in the north Italy, as if I remember it was in Norway, but in a setting in epidemiology with a low rate of resistance. So these are patients with community-acquired pneumonia, and the use of rapid diagnostic test with multiplex PCR that was done mainly in BAL has led to a higher, lower time to targeted treatment compared to standard of care. So in the next slide, we can see that patients that were enrolled in intervention arm had a higher rate of pathogen-directed treatment, as a higher rate of escalation from narrow spectrum to broad spectrum antibiotics, and also a higher rate, even though not significant from a statistical point of view, higher rate of de-escalation therapy. So the turnaround time was clearly much lower in intervention arm, and also the time to administration of targeted treatment in this trial. Next slide. This is another interesting trial conducted in the US. This was a single center study in which patients were enrolled with the suspicion of pneumonia, so not necessarily pneumonia, and they assessed the use of multiplex PCR in terms of any de-escalation or re-escalation. So there was two cohorts, one with suspected pneumonia and one with actual pneumonia diagnosis. And in this latter cohort, there was a higher rate of patients that receive escalation from gram-positive and any de-escalation, especially when they have gram-positive or gram-negative identified pneumonia. Next slide. And we have also some meta-analysis of randomized control trials, so showing that generally there's no association with mortality, but the use of PCR panel has led to a higher rate of adequacy of initial treatment compared to standard of care, and the time to targeted treatment that is shown in the next slide. So this is a time to effective antimicrobial treatment in terms of patient enrolled in the PCR groups. So if we want to go back to our clinical study, clinical case, sorry, we decided, because in Italy, at least in my center, we have nearly to 40% of Klebsiella pneumonia that is resistant to piperacillin and tazobactam when it's CTXM positive. We decided to shift to meropenem, and this was the final treatment. So our PCR was led to effective treatment in our patient, and we were able to de-escalate linezolid and azithromycin because we deemed not useful in this case. Next case is a 21-year-old girl that was admitted in September 21 with newly onset acute myeloid leukemia, and she had some episodes of febrile neutropenia during a treatment with a buffly regimen. And in September, as the end of September, as a febrile neutropenia with respiratory failure, and she started the treatment with piperacillin tazobactam plus linezolid, and then after 38 hours, because she had no response to fever and worsening of respiratory failure, she was shifted to meropenem. We performed a CT scan, which is shown in the next slide. As you can see, we had a pneumonia. We had typical pneumonia with bilateral and patchy infiltrate, I would say multifocal infiltrate, especially in the lower lobes. So what we decided to do is actually to do, I think this is next slide. Yes, we did BAL with biofire pneumonia panel plus, which was positive for parainfluenza virus type 3. So at the moment, she continued to have fever, respiratory failure. She has negative procalcitonin and 23 of CRP. So the question would be for the audience, and maybe we can discuss what about treatment. Next slide. What would you do in these cases? So would you discontinue linezolid, discontinue meropenem, would discontinue all antibiotics, or will you continue all antibiotics? Think a little bit, and then I will tell you what we have done. So what we actually did is to discontinue all antibiotics, because the clinical picture was really clear from the CT scan. We had a patient with a clear pneumonia. We had a diagnostics of pneumonia of parainfluenza type 3. So we decided that this is a viral infection, and we decided to discontinue all type of infection. I would say that we had a large, broad discussion with hematologists, which they wanted to continue antibiotics, but at the end, we decided to discontinue, and the patient did very well. I want to let you show some data about diagnostic performance, especially critically ill immunocompromised patient. This is a recent paper published on critical care, in which 114 patients with immunosuppression, especially hematological and oncological patients, were included. As you can see, when the use of BioFire Pneumonia Panel Plus PCR, there was a higher rate of detected pathogens, and there was some pathogens that were not detected by the panel, but I have to say that these kind of pathogens were not clinically meaningful. For example, there was some coagulase negative staphylococci, lactobacillus, enterococcus faecalis that are clearly meaningless in case of pneumonia. And as you can see, the negative predictive value was 0.98. So a negative PCR can really rule out in this kind of patient that the patient has bacterial pneumonia, like in our cases. So we can discontinue safely, even in immunocompromised patient, in my opinion, all kind of antibiotics. So the next slide. This is the third and I think last case. This is a 71-year-old male, like the previous one that I show you, that was readmitted in the hospital for acute abdominal pain. She had a colectomy. She started renal replacement therapy for an AKI, prolonged mechanical ventilation, and after 5 days, he has a new onset of fever, hypotension with response to fluid challenge, and chest X-rays show a new opacity and infiltrate. So what can we do with this patient? Next slide. Should we start empirical treatment, or can we hold antibiotics and start directly target treatment if we have already performed a BAL and we are pending results for BioFire Pneumonia Panel Plus? So this question was tried to answer by the INAIL trial that is shown in the next slide. So the INAIL trial was a randomized control trial that enrolled the patient with pneumonia and his hospital-acquired pneumonia and ventilator-associated pneumonia, which there was a clinical sample, a respiratory sample, and the intervention treatment, they wait for respiratory sample to start directly the target treatment. Next slide. The patient enrolled in this trial were mainly patients with the hospital-acquired pneumonia. You can go with the next click, so I can show you this. There was a hospital-acquired pneumonia. As you can see, there were a lot of patients with SARS-CoV-2 infection, which is, I think this is very important to understand the context of the study. Many oncological patients and patients with the SOFA score, main SOFA score of 6.8. So the primary endpoint that is shown in the next slide was the time to the antimicrobial stewardship program. That the primary endpoint, there was 21% of absolute improvement in this kind of goals. Unfortunately, in this next slide, there was a secondary endpoint. There was a non-inferiority in terms of safety. This, unfortunately, this endpoint was not reached. So the clinical cure 14 days was lower in the patient in the intervention arm than compared in the standard of care. However, there are several other studies showing different results. So this is a real-world evidence study coming from a large multi-center study conducted mainly in Italy that assessed the use of a multiplex PCR in patients with ventilator-associated pneumonia. And in most cases, the clinician decided to start the treatment only after the results of the test, and we can say that there was no association with mortality. So I think this is safe to do in our context. And as you can see, the multivariable analysis for TDA mortality was a SOFA score, solid neoplasm, a previous isolation of carbapenem-resistant Pseudomonas. However, in the patient that use syndromic panel for etiological diagnosis of pneumonia, there was higher rate of de-escalation and appropriate treatment from day one. So in the next slide, I say that what we did in this patient with the BIP, again, we found a Klebsiella pneumonia. This time was OXA48 positive patient. The next slide, we decided to start cetasium avibactam, as you know that this is an active treatment for OXA48 positive Klebsiella pneumonia. Next slide. And at the end, the standard susceptibility tests show that this patient has Klebsiella pneumonia resistant to all antibiotics like expected, and with resistance to meropenem and valbarbactam as expected, the susceptibility to ceftazidime avibactam. Next slide. And this is my conclusion. So I think that the rapid multiplex PCR panel can be useful to improving antimicrobial stewardship in different kind of patients, critically ill, immunocompromised. I think that other studies are needed to assess if we can withhold antibiotics pending results of rapid molecular assays. And thank you for your attention.
Okay. So thank you very much, Michele. Thank you to Vittorio. And it's my time to go through this topic. And please go ahead. Next slide, please. Okay, and I started to think how much we have to work with lower respiratory tract infection and above all lower respiratory tract clinical specimens. Next slide, please. And for doing this, I selected this paper. And this paper is a global paper in which there is a sort of estimation of the impact of lower respiratory tract infection in all the world. As you can see here, we have very huge number, 344 million of clinical episodes. And if you look at the main pathogens, this paper is related to the isolation in 2021. Streptococcus pneumonia remained one of the first pathogen, but you can see also the second one, other viral etiologies, mycoplasma, and going into the severity and probably in the hospital acquired or in a ventilated pneumonia, you can go through different pathogens, nosocomial pathogens like Staph aureus and Klebsiella pneumonia. And the color in the map are very indicative of this huge number of isolates. Next slide, please. So we know what we are talking about. This is the consensus just published in Clinical Microinfection under the memory of Emanuele Russo that was already mentioned before. And we can go ahead, please, in the next slide. And just to make me possible to make some observation, I started with the key question that we already discussed with Vittorio, and we know exactly what we are doing. So this is the first question related to the community acquired, and the question was on the rapid microbiological testing. Next slide, please. And I selected this paper, and this paper was just trying to make some observation on the combining use of multiple PCR and serum procalcitonin to reduce the antibiotic exposure in clinically ill patients. So this was a multi-center study. And the study was starting in 2018, finished in 2022. 400 patients were randomized. And as you can see here, directly in the conclusion, this author said that in ICU patient, when you have a community-acquired pneumonia, a combined strategy of multiplex PCR, so molecular method, and serum procalcitonin failed to reduce antibiotic exposure or improve outcome on day 28 compared to the usual care. So it's not easy to find solution. The next slide. One of the reasons is this one. We have a plethora, as already mentioned by Vittorio, a plethora of possible agents responsible for infection, as you can see here, starting from virus, bacteria, and also many multi-drug organisms, as already mentioned by before. So, and antimicrobial resistant markers are very useful to detect it. Next slide, please. So it's very easy to have all these kind of targets in one panel. And when you look at the panel of pneumonia, that is, of course, a nested real-time PCR, very easy to use. And in few minutes, you can have a process, you can have a results, and you can detect bacteria, typical and atypical, virus, and also antibiotic-resistant genes all together. You can have some important information, including some quantification. So we have some reports related to the semi-quantitatively presence of the microorganisms into the sample, into the respiratory sample. Next slide. Okay, but sometimes we have discussion about the specimen. Already mentioned the validity of bronchoalveolar lavage or endotracheal aspirates, but what about the sputum, the quality of the sputum? If you look at the quality of the sputum, this is one of the major clinical specimen arriving at the microbiology clinical microlab. And you can see here that there is a criteria, and the criteria is both macroscopic and microscopic, just to understand if what you are doing or if you are processing a good material. As you know, the sputum is a clinical specimen heavily contaminated from the passage from the oral microbiota. And the criteria that you can see in this small table that is called the Bartlett criteria, looking at making a simple gram stain, you can just have an idea about how much is deep, how much can be indicative this kind of sputum of the lower respiratory tract infection. And it depending on the number of neutrophils with respect to the epithelial cells related to the sample, to the microscopic vision. And so you can obtain a sort of total score, a grade, in which you can define if the microscopic is okay. Can I have the next click? Thank you. So be careful when you assess the sputum specimen to be processed if they contain the neutrophils in a number that can be 10 to 25 per field, with respect to the number of epithelial cells. Next slide. This paper just have a look of this kind of study on using the sputum sample, if it's the good quality and if the good quality is related to the microorganism. And you can see here in this paper, you can find a good correlation between a good quality of the specimen and an isolation of a pathogen. This was true for Streptococcus pneumoniae, Staph aureus, Haemophilus influenzae, Morosella catarrhalis, Klebsiella pneumonia, and Pseudomonas aeruginosa. So we have a good correlation of this kind of criteria if used. The next one. And this is a study, you can see here, published in 2019, in which this author, they make a sort of a revision of the literature, systematic revision of the literature and the meta-analysis. And the idea was to put together the usefulness of sputum gram stain and the diagnosis in community-acquired pneumonia. You can see here how much the algorithm used to include the manuscript, the articles reviewed, and they make eligible only 20 paper, but 20 paper are correct. So next click, please. And you can see here the results. So you can see the results of the meta-analysis in relation of the sensitivity and the specificity. You can see the two different line in the slide related to Streptococcus pneumonia, Haemophilus influenza, Staph aureus, and gram-negative bacilli. Next slide, please. I summarize this kind of information saying, or the results of the study, saying that sputum gram stain is sensitive and highly specific for identifying causative pathogen in adult patients with community-acquired pneumonia. So that was for gram stain. The next slide, please, obviously included. This is what we obtain for the ventilated hospital-acquired pneumonia, a strong agreement to use molecular methods. And here is, can I say, next slide, please. Can I say is absolutely more indicate for many reasons. One is also the severity of the patient and also the reduction in time necessary for obtaining a result. And the third is the good quality of respiratory sample that we can obtain from this kind of patient. Again, we have here the same panel of before, the same panel for an incredible number, a huge number of pathogens responsible for pneumonia in all cases. And of course, in case of ventilated associated pneumonia, above all in ICU, you can have more prevalent isolation of gram-negative multi-drug resistant organism, including multi-drug with multi-drug markers. Next slide, please. So this is again another study. This study was published recently in journal Clinical Micro. It was an evaluation of the BioFire film array pneumonia in terms of linearity and accuracy of the results provided by the panel with respect to the reference method. As you know, in any kind of study, we have to compare any kind of novelty of new methods with the conventional gold standard method. So this was the study. In addition, in this study, they make the comparison. In a case of diversity, they use digital PCR. So, and the digital PCR was centrally performed because this is a multi-center study from the US. Just going, please go next slide, please. So the conclusion of the study was that they make the very nice comparison because the panel was able to detect, of course, all the gram-positive and gram-negative, and in both cases with great sensitivity and specificity. The sensitivity of this assay was very high in both clinical specimens. So, and there was some variation in the first 5 between 75 to 91.7%. So the sensitivity was very high and also the specificity, 91%. Next click, sorry. The second observation that I want to point out, because of course, we find normally this kind of observation. We have a discrepancy between a molecular methods and the cultural method. Sometimes these kind of differences in specificity and sensitivity are related to this. Obviously in the panel, in the molecular panel, we are able to find more positive sample with respect to the cultural method. So the determination is different. Next click, please. Okay. Obviously, when we think about the microorganisms, as already seen in the case presented before by Michele, we have also some possibility to have in the molecular panel the presence or the absence of antimicrobial resistant genes. And this can be an indication in a stewardship program to use an antibiotic or to the scale an antibiotic if already used another one. So another good information. Next one, next click. Okay, so the indication of the study was This panel could be utilized for rapid de-escalation or initiation of antibiotic, improving the patient care outcome. So obviously, this is very clear above all in severe infection. Remember also the turnaround time that is very different from the cultural method, of course, from the antimicrobial susceptibility testing, even if we now have a phenotypic rapid method that are just an adding value of all this kind of testing. So next slide. I think that I am very close to my conclusion, but it's very clear that we have advantages and limitations on rapid molecular methods. The first is speed, because we have absolutely short the time of having some information, at least of indication of the species and some resistant genes. The sensitivity, we can say that they are much more sensitive. Starting another point, how much this sensitivity is real. Sometimes it's very difficult to understand, above all when we have colonizing microorganisms or dead organisms inside into the sample. Obviously, the breath syndromic panel are able to detect altogether potential pathogens. So we have also in simultaneous situation many microorganisms together. Sometimes it's not easy to understand which one is the responsible. In the example before, for example, we have some positivity, different positivity in the panel of Michele, but they were 2 viruses or 2 bacteria, but sometimes we have different targets becoming positive. So in my thought, I think that we need to be more precise and to be more in contact with the clinic to understand better the action of any specific organism. And also, absolutely for sure, the panel are a good guide for faster de-escalation or narrowing antibiotic therapy. So this is another story, very important. The next slide, I think, will start with the indication of digital. Just a few words on the digital PCR. Next slide, please. The digital, as already mentioned by Vittorio, is not, we don't have a lot of data on that, because digital PCR is a new technology, and the new technology in which we have a procedure that has an endpoint PCR that is split in different PCR reaction, as you can see in all the dots that you can see inside. The center of the story of digital PCR technology is the partitioning. So the partitioning means that you have a target partitioned in many parts, randomly distributed in all the partition. So you have an amplification, and you can make a calculation following a Poisson statistics that can be used for calculating the average amount of target DNA. This seems too difficult to understand, but another slide, please. Next, please. Yeah, the Poisson distribution is shown here. So is a sort of randomly distributed in each partition, and there is a calculation of probability of the presence of a possible target. This is very specific. Please go ahead. And we have many applications coming up in this kind of procedure. The first characteristic of this kind of technique is the absolute quantification without a standard curve. So it means that we can compare results obtained in different lab by different hand, because we have an absolute quantification. We have a less affected by poor efficiency of amplification, less affected by inhibitors present in the sample, and also a good sensitivity and an excellent precision. All these kind of characteristics are very important, so we have to design study for the future for having more information about the potency of digital PCR. Application. can be applied in many fields. First, the quantification of a pathogen load is used. We found paper already published in viral infection. So this is an important information, the quantification. Accurate quantification of targets with high sequence variability, so it's able to do that. Accurate quantification of sample in which I told you there is inhibitors inside into the sample, including antibiotic. Precise quantification when we have a low pathogen loads, or important, when we have rare mutation, so is able to see mutation that we don't know at the beginning. So can be interesting to have this kind of technology in sample just to detect also mutation and any other information. So just to give you an idea of the application that we can have in the future with the digital PCR. The next slide, I think that is my conclusion, and the conclusion is obviously that laboratory diagnosis of pneumonia has different methods, and the consensus was able to define better the role we understand very well that is as a potency in the characteristic of the test. So obviously we have difference from the cultural point of view. The culture are easy to perform and probably cheaper, but the turnaround time is longer, and sometimes we have low sensitivity, especially if the sample is taken after starting antibiotic treatment or when we have a severe infection. Obviously, molecular assay, the cost is a concern, and we need, in some cases, in the single class, we need to know better or to have an hypothesis of the pathogen. For sure, the multiplex is a very interesting procedure, high turnaround time, high sensitivity. The costs continue to be a concern, but for sure, in severe patients, in situation in which you have to determine the decision of an antibiotic to save the life of the patient can be absolutely important to use. And thank you very much for your attention. I finished my presentation here. Thank you.
Thank you, Dr. Stefani. And thank you for our speakers and your participation today. I know that we're out of time in terms of Q&A, but I did want to get to just one question if we can before we close out. And those who are in the audience, please continue to send in your questions in the control panel, and then we can try to get to those after the webinar as well. But one question that we had here, so thinking about outcomes like reducing time to targeted therapy, and in terms of that, what do you think are the most important factors for successful collaborations between the lab and clinicians to optimize the way clinicians act on the diagnostic strategies you spoke of today? If anyone has any thoughts on that.
I leave the answer to Michele.
Okay, I think it should be the laboratory perspective and the clinician perspective. Yeah, I think this is the key question. The key question is a strong collaboration. And what I saying to my collaborator is that if we have a laboratory that is open 24 hours per day, we have to be there 24 hours per day. Otherwise, it's unuseful that that laboratory stay open with giving results. There's no one that can interpret the results in the patients. So, and I think, unfortunately, that we are the only one that can clearly interpret the results, especially in a critical patient with the genes of resistance. So, if we have, for example, for the results of a multiplex PCR, the results of some specific genes for resistance, OXO48, NDM, etc., I think that one expert of antimicrobial therapy should be there to translate the results of the laboratory to the treatment of patients. So yes, we have to combine and everything. I have to say also that we have combined also pulmonologist to collect samples or intensivist to collect samples. So, and also the transportation of samples into laboratory should be clearly organized, because sometimes we have samples collected, the samples stay in the ICU for 1 day and goes to the laboratory the next day. So in this way is unuseful. So I think this is a great question and probably one of the most difficult questions to answer.
If I can add something, in any case, Michele, I think that we need, so our discipline are the side of the coin of the other. So if I improve something in the lab, the answer is you have to improve from the other side. The person that is able to pick up the information and discuss with me if I use a molecular method that's a short turnaround time, for example. So I think that more and more we are in the line to be equal. So if I am rapid, you have to be there to receive the rapid tool. And we are in this discussion. In some lab we have this kind of very nice collaboration, but we have to work more on this.
Dr. Sambri, do you have any thoughts as well before we close out?
Yeah, I can make a comment on that, because I believe that nowadays the resources that we have available in the laboratory are just limited. We have no unlimited resources. So we need to find out a way to use these resources in the best possible way for the end beneficial of the patient. So I believe that we are unable, and I guess also that the clinical side of the story, like Stefania was just saying, is not capable to state which patient mostly would benefit from the use of rapid microbiology. I'm strongly pushing on the use of artificial intelligence algorithm that can be, the right answer to the question, who is the right patient to be, treated with rapid microbiology. Yeah. Nowadays, we are still in a system, in a situation in which we try to use the resources as much as in our best way, but this is not enough. This is not enough, because the resources will become lower and lower and lower. We need to reserve the resource to the patient that are at high risk, and I don't see any alternative to the use of AI.
I agree.
Yeah, absolutely. Well, I know that we're running over a little bit. I'd love to get to more questions, but unfortunately we are out of time today. So to our speakers, thank you so very much for joining today and for your insightful presentation. And thank you very much to our audience for joining as well. Just a quick reminder, you will be receiving a follow-up email with access to the recorded archive for this event. So you will have that for your own records. But again, just final thank you to everyone and to our audience for joining. It's been a pleasure to be your moderator. And on behalf of the team and our sponsor, bioMérieux, we thank you for joining us. So until next time, take care and bye for now. Bye-bye.
Bye-bye, everyone. Ciao, Stefania. Ciao, Michele.
Ciao, ciao a tutti. Bye-bye.